I would like to express my deep thanks to North B and the organizing committee for allowing me to share in this scientific meeting. Mr. Chairman and the dear colleague, I will talk about the recent guidelines in the treatment of rheumatoid arthritis, and this is followed by treatment of spondyloarthropathy. You know, all of these cells play a role in the pathogenesis of rheumatoid arthritis, like the antigen-presenting cell, the dendritic cell, the B and T lymphocytes, which secrete a lot of interleukins and inflammatory cytokines, which result in the destruction of the joint. So there is increase there is advances in the treatment of the rheumatoid arthritis due to the discovery of the biologic therapy, which are monoclonal. Most of them are monoclonal antibodies, which are neutralizing the tumor necrosis factor alpha, interleukin 1, the costimulatory T lymphocyte blockade, the B-cell depletion, and the interleukin 6. Before I start the guidelines for treatment of rheumatoid arthritis, I would talk about some definitions which will be used in the guidelines. Early rheumatoid arthritis, it is known that in the duration of the disease from the starting of the symptom is less than 6 months, not since the diagnosis, the start of the symptoms. The established rheumatoid arthritis, the duration of starting symptoms is more than 6 months. The disease activity categorized as low disease activity or moderate or high, and usually we combine the moderate and the high as our group. Rheumatoid arthritis remission, there is definition from the American College of Rheumatology. AlAzhar defined in rheumatoid arthritis remission means in the number of swollen joint and tender joint, CRP or DSR is less than 1 for each one. Or we can calculate the disease activity by the best score. The disease activity score should be less than 2.6. This means the disease remission. Over this means low disease activity when it reaches 3.3, and the high disease activity when it reaches 5.1. The optimal dosing of any drug is the dose of this drug which achieves the target of this drug. What is meant by disease-modifying anti-rheumatic drugs? This is a group of the drugs which can make changes in the course of the disease, as like Dr. Sabila told. There are conventional or synthetic drugs, اللي هي الميثوتريكسين واللوبيلوناميد والسلازوفايرين. And the Marcus failure means a failure of this drug to achieve the disease remission, or there is occurrence of side effects. Biologic failure, the same definition, lack of efficacy, or there is a side effect to stop this drug. A secondary biologic failure means in the biologic therapy, when it is used, get a benefit from this and the disease is controlled. The disease activity is controlled for some time. After this time, there is increase in disease activity. This is called secondary biologic failure. A traditional or a conventional synthetic demand as we told before, hydroxychloroquine, levodopa, or salazovairin. The monotherapy usually means methotrexate. If there is combination, means combination of 2 or 3 MRs. There is a new class of drugs which is used in the treatment of rheumatoid, which is known as anti-JAK pathway, which is now it is drug is tofacitinib, but unfortunately it is not present in Egypt. The biologic, we can classify the biologic therapy to TNF blocker or non-TNF blocker. The TNF biologic includes the الاداليموماب، السيرتوليزوماب، الاتانوسيرت، الجوليموماب or الانفليكسيماب. المالتي ان اف بيولوجيك الاباتاسيبت، الريتوكسيماب or التوسيليزوماب. We mean below dose corticosteroid less than 10 milligram or high dose it is more than 10 milligram, and usually we use corticosteroid for short duration, means less than 3 months. Recommendation, this is the recommendation for an early rheumatoid arthritis. The first recommendation, we should be aggressive in the treatment of early rheumatoid arthritis using the concept of treat to target. We have a target to produce disease remission, so we should treat the patient to this target. The second recommendation and the third recommendation, we start with early rheumatoid, either low disease activity or moderate or high disease activity. We usually start with the conventional DMARD monotherapy, means methotrexate. مع الفيلير fourth recommendation, if we give the patient DMARD, the conventional DMARD monotherapy, either with or without corticosteroid, if it is failed, if the disease remains moderate or high, we should use either DMARD combination or TNF inhibitors or non-TNF inhibitors. We should choose between either we can use DMARD combination like methotrexate with salazobirine, loperamide with salazobirine or hydroxychloroquine. This is a dual therapy or 3 therapy. Or we can use TNF inhibitors or non-TNF inhibitors. And the choice depends on the side effect of the drug, the cost of the drug, and associated comorbidities in this patient, and the burden of the use of this drug. Fifth recommendation, if the disease activity is still moderate or high, despite we use either the combination therapy of DMARD or TNF, either monotherapy or with methotrexate, we should aid the TNF مع الDMARD more than ان انا استخدم التوفاسيتينات مع الميثوتريكسيت. البريفيرابل ان انا استخدم الDMARD الميثوتريكسيت with الTNF blocker more than التوفاسيتينات. طبعا احنا we have no توفاسيتينات فما بنستخدمهمش. بنسأل the recommendation if the disease is still active, moderate or severe activity, despite ان انا استخدمت the combination of DMARD or a biologic therapy, we can add small dose of corticosteroid for the shortest duration, less than 6 months. And if there is a response to the DMARD therapy or biologic therapy, either TNF or non-TNF, and then flare of the disease occur, we can add small dose of corticosteroid also for a shortest duration. This is the algorithm how to treat early DMARD, which summarizes the previous guidelines. As regards the established rheumatoid, we mean established rheumatoid, the patient fulfills all the criteria and has a disease more than 6 months. The first recommendation is also to be aggressive in the treatment of established rheumatoid arthritis using treat to target concept. And second, if the disease of low activity or moderate or high disease activity, we start also the monotherapy of DMARD, the methotrexate. After the failure, if the disease, we use the DMARD monotherapy, we can fail and the disease is still of moderate or high disease activity, we can use a traditional DMARD combination or an anti-TNF or an anti-NF or a tofacitinib drug. If the disease activity, if we use TNF inhibitors in this patient and is still active, and this patient is not on we can add to this patient, we use TNF as a monotherapy, and the patient is still has a moderate or severe activity, we should add methotrexate, 1 or 2 من conventional DMARD. More, it is better than the use of TNF monotherapy. Second, if we use 1 minute TNF inhibitors and the patient still have a moderate or high disease activity, we should use non-TNF inhibitors with or without methotrexate. After the failure of TNF, if we use 1 minute TNF inhibitors, we can use non-TNF inhibitors with or without methotrexate. Rather than ان انا استخدم another TNF inhibitor with methotrexate. The change or switch from one class to another should be done after 3 months of the drug. We should monitor the patient and the disease activity every 3 months. If there is still activity, we check or add another drug. Recommendation: if the disease is still active, moderate, or high disease activity, despite an استخدم 1 non-TNF inhibitors, I can use another 1 non-TNF inhibitors with or without methotrexate, and we can use another non-TNF inhibitor with a different mode of action, because a non-TNF is multiple groups, interleukin-6 inhibitors, or anti-CD20, or rituximab, or can use other non-TNF inhibitors. If the disease remains moderate, if the disease is still of moderate or high disease activity, after the use of 2 or more sequentially TNF blocker, يبقى استخدم another non-TNF blocker rather than TNF blocker. And if I start with TNF, 1 TNF, and it is failed, and I use another TNF, and it's also failed, it is better to switch to non-TNF inhibitors. And if the disease remains active after the multiple use of multiple sequential TNF, and I have no non-TNF inhibitor, I can use tocilizumab with or without methotrexate. If the disease activity is still high or moderate after the use of at least 1 TNF and another 1 non-TNF inhibitors, I can use another non-TNF inhibitors with or without methotrexate. If the disease is still high activity, using multiple DMARD or TNF inhibitors or non-TNF inhibitors, I can use short term of corticosteroid less than 10 milligrams for less than 3 months. And also, if the patient develops any flare at any time, use a small dose of corticosteroid. The concept of tapering of the dose. If the patient gets to the disease remission, and disease remission should be sustained for at least 6 months or more than 6 months, then I can taper the doses of the drugs for the cost and for the burden of the side effects of these drugs. So if the patient is in remission, taper, the first is the DMARD, the conventional DMARD, the methotrexate and its colleagues. Then taper in biologic therapy, either a TNF or a non-TNF. And the tapering is usually by either reducing the dose or spacing the interval between the subsequent doses. Taking into consideration when the patient is on sustained remission. But if the patient is in low disease activity, continue the medication without tapering. and should the patient be informed that in tapering the doses of the drug can reduce flare of the disease and increase the activity of the disease again. But never discontinue all the drugs for the patient who reach to sustained remission, because there is increased risk of flare and increase the activity. There are two additional recommendations for the last recommendation. We told about if the patient failed مع الDMARDs, we can use TNF inhibitors, and if it is a fail, we can use non-TNF inhibitors. But we can use another TNF inhibitors after the failure of the first one, because in the clinical trials proved the efficacy of the second TNF after the failure of the first one. And if the patient has a moderate and severe disease activity in spite of using of multiple non-TNF inhibitors, and these patients are TNF naive, and doesn't use TNF inhibitors before, we can start after the non-TNF inhibitors, we can start TNF inhibitors. This is the algorithm. Before using the DMARD or biologic drugs, we should follow up the patient regularly, and we should screen the patient for TB. The screening for tuberculosis should be done for everyone before taking biologic therapy. Either this person is of high risk group for developing latent TB or not. And there are a great group of persons who are at great risk for tuberculosis, like the close contact to patients with open TB, or visiting an area with increased incidence of TB, or visiting foreigners with increased incidence of TB. How to screen for tuberculosis? We should screen by the initial screening test for TB is the tuberculin skin test or interferon gamma release assay. البيتا اللي هو الانترفيرون جاما ريليز assay is better than tuberculin test, because in the tuberculin test is usually give false positive result in patient who took the BCG vaccine. So it's recommended in هو either tuberculin skin test or gamma radioimmune assay. لو انا عملت التوبركلين تيست or الانترفيرون جاما راديومين assay, it is positive. And if the patient had positive tuberculin test, we should do chest X-ray, and if the chest X-ray is positive, يبقى we do Zen Nelson examination for tubercle bacilli. If the skin test is negative and the patient has no risk factor for developing latent TB, يبقى there is no further work up, and I can give the patient biologic therapy. But if the patient has negative tuberculin test, and it is with immunosuppressive drug, and has a risk factor for latent TB, يبقى I could not exclude latent TB, and I repeat this skin test after 3 weeks after the initial negative result. If it's still negative, I can give the patient the biologic therapy. But if the patient has active positive tuberculin test or gamma interferon, I should, if it has active TB, I should treat the patient completely from tuberculosis before starting the biologic therapy, and refer this patient to pulmonary specialist. If the patient has a latent TB, not active TB, I can start the antituberculous drug, and after 1 month from this antituberculous drug, I can start the biologic therapy. And for latent TB, start the antituberculous drugs only for 3 months. الفولو اب بتاع البيشنت ايذر اللي هم بياخدوا الكونفنشنال ديمارد او البيولوجيك ديمارد بيبقى تريتمنت في الفيرست 3 months. First every 2 to 4 weeks and followed by 2 to 3 months. There are some comorbidities, some association of other diseases with rheumatoid arthritis. How I treat those patients? As regards the patient, if has congestive heart failure, I should give combination synthetic DMARD, methotrexate, or levodopa, salazotyrine, or hydroxychloroquine. It's better to give this patient this drug more than TNF inhibitor, especially if the heart failure of grade 3 or 4. Because the TNF inhibitor aggravates the symptoms of the heart failure. But if the patient has compensated heart failure, I can use the anti-TNF inhibitor. If the patient has hepatitis B, the patient with hepatitis B, either treated from hepatitis B or receiving treatment of hepatitis B, I can start the biologic therapy. But I can follow the same recommendation as a patient has no hepatitis B. But if the patient has natural immunity for our previous exposure للهيباتيتس B, يبقى برضك I can use the same recommendation. If the patient has hepatitis B, active hepatitis B with no treatment, I never will start never start the biologic therapy and give the patient synthetic DMARDs العلاج. Take the patient took the antiviral medication. As regards the hepatitis C, also patient receiving treatment for hepatitis C or complete the treatment for hepatitis C, I can follow the same recommendation. But the patient, if the patient not receiving treatment and not require antiviral treatment, I give the patient synthetic DMARD, not the biologic DMARD. There is trials or studies showing in the biologic therapy we increase the viral load on those patients with hepatitis C. But and the other studies show that there is no increase in viral load. So it's better to start with the antiviral therapy and give the patient the markers. If it is failed, we can follow with TNF or non-TNF inhibitors. As regards the malignancy, a patient with history of treated skin malignancy, melanoma or non-melanoma, I give the patient the mark not a TNF or biologic A therapy. If the patient because there is the increased recurrence of the skin malignancy if we use a TNF inhibitor. But if the patient has moderate or high active disease with low-grade melanoma or non-melanoma, I can start a biologic therapy with close observation for this patient for the rest of another rare of this malignancy. The lymphoproliferative diseases, better ان انا استخدم rituximab because it is proved the treatment of lymphoproliferative disease, and I can use a combination of synthetic DMARD or a non-TNF biologic like abatacept or tocilizumab or rituximab. With serious infection, sometimes the patient has repeated serious infection. If the patient has this serious infection like pneumonia, I can use a combination of the DMARD more than the TNF. I can use some non-TNF اللي هو الاباتاسيب more than the TNF because in the abatacept the least biologic therapy which can produce serious infection. And also in the patient rheumatologist بيبقى عندهم great experience مع conventional DMARD more than the TNF. فيبقى لازم the benefit and side effect of the biologic therapy in those patients. I stop for this and I talk about the treatment of the guidelines for treatment of spine. the latest guidelines for treatment of axial spondyloarthropathy. أنا مش هتكلم طبعا عن spondyloarthropathy الدكتورة سميرة قالت عليها بالتفصيل، بس احنا هنستخدم نفس الترمينولوجي regarding الدماغ أو البيولوجيكال ثيرابي. الريكومنديشن in 2016 put some principles called the overarching principle in treatment of an axial spondyloarthropathy. Axial spondyloarthropathy is very severe disease with many manifestations and many system affection, so it needs a team for its treatment, and this team should be coordinated with the rheumatologist, because the rheumatologist knows the whole extent of this disease with its comorbidity. And also a primary goal of the treatment with the SPA is to maximize the long-term health-related quality of life through control of the symptoms and signs of inflammation and the prevention of the progressive structural damage, to normalize the function and the social participation. And we should have a pre-treatment goal. And optimal management of AlAzhar requires a combination between non-pharmacological and pharmacological treatment, non-pharmacological like physical therapy, which play an important role in SPA more than in rheumatoid arthritis. And the patient should be treated with the best care, should be given to this patient. And the management should be shared between the patient and the physician. In السبونديلوارثروباثي التريتمنت بتاعها فيه high individual and medical and social cost, and all of them should be considered in ensuring the better management of the patient, but not on the expense of the best care for the patient. Recommendation, the first recommendation, we should treat the patient, and the treatment of each patient should be individualized according to the symptoms and signs of this patient. It has axial spine affection, or has extra-articular manifestation, or has peripheral joint affection. And also taking into consideration other comorbidities and psychological factors in this patient. Recommendation, the second recommendation, the patient should be monitored during the treatment. And this monitoring for the inflammation and the structural damage with the clinical finding, laboratory test, and the image. And should be done with suitable tools. For the follow-up and for the monitoring of this patient, we can use the ASAS guidelines for the evaluation. اللي هي الباساداي او الباسيفاي، والاحسن منها ان انا استخدم الاسادس، لان الاثنين الاولانيين بيعتمدوا على الاوت كم اوبزرفيشن بس، لكن السكند بتعتمد على بعض الاوبجكتيف لاين CRD وESR. لو انا عندي السبار patient presented with early spondyloarthropathy, MRI for the sacroiliac joint is informative and diagnostic. If there is affection with bone marrow edema, for the MRI of the both sacroiliac joint, this is the early spot. But later on, يبقى MRI for spine, showing an osteophyte and the bone marrow edema on the vertebrae. The MRI not used for monitoring. يعني no advice to repeat the MRI to follow up for those patients because it is too expensive. And also a radiograph, X-ray, and a plain X-ray for the sacroiliac joint is used because to be posted it needs more time. But we can repeat X-rays, the evaluation of the patient every 2 years. Treatment should be guided according to a series target for the treatment of those patients. And the target of this patient is to reduce the inflammation, to improve the symptoms and signs of the patient, and to prevent the damage progression. disease is the ultimate goal of our therapy. The patient should be educated about spondyloarthropathy as a disease and encourage them to do regular exercise and stop smoking. The physical therapy should be considered either at home or at physical therapy centers. The smoking is very important for the patient with SPA because there is correlation between the smoking and the activity, or it increases the inflammation. The patient suffering from pain or stiffness, we start to use a non-steroidal anti-inflammatory is the first line of therapy. And we should use the non-steroidal with full dose, the maximum tolerable dose, and continuous use of the non-steroidal inflammatory drug is better than the use of non-steroidal on demand. If we use non-steroidal, which is the first line of treatment, we use the maximum dose and the continuous use. Because in the two found that in the continuous use of non-steroidal can reduce the inflammation and slow the disease progression. But we should monitor the patient on non-steroidal. If there is failure of the first non-steroidal, after 2 weeks from therapy, we stop this drug and start another drug, non-steroidal, another one, non-steroidal drugs. A failure of 2 non-steroidal drugs within 1 month, we should start TNF inhibitors. We can use, if there is contraindication to non-steroidal anti-inflammatory drug, we can use the paracetamol or the opioid-like drugs for analgesia to stop pain. But these drugs doesn't change the course of the disease. Non-steroidal can change the course of the disease, and the failure of 2 non-steroidal at least for 1 month, we should start directed to TNF inhibitors. If the patient has peripheral affection, means the affection of 1 or 2 large joint, as Dr. Sabina said, shoulder or head or knee. If there is affection, we can use local corticosteroid injection. If had 1 joint affected, we can use local intra-articular corticosteroid injection. But if it is multiple, more than 1, we can use salazobiolene in the peripheral joint affection, up to 3 grams per day. Patient have pure axial SPA and not should be normal and should be treated with conventional synthetic, not should be treated with conventional synthetic demand. If the patient has pure axial SPA, there are no place for the treatment for conventional demand, methotrexate or salazobiolene, hydroxychloroquine or whatever. But if it has a peripheral joint affection, we can use the salazobiolene. No place for conventional demand in the treatment of axial SPA. Biologic therapy should be considered with patients with persistent high disease activity despite a conventional therapy. What is a conventional therapy? In our non-steroidal anti-inflammatory drug, if it is the first drug of choice, or a local corticosteroid or salazobiolene in the peripheral joint affection. But there is many requirements before starting the biologic demand in the treatment of SPA. The first step in our diagnosis of spondyloarthropathy, which should be done by a rheumatologist, fulfilling AlAzhar criteria for spondyloarthropathy. And the diagnosis based on the clinical picture, laboratory, and the imaging techniques. The next step, if this disease is active or not. I should search for elevated CRP or there is inflammation in the MRI of the sacroiliac joint or the spine in the later condition, or definite radiologic affection with preliminary X-ray. Should definite diagnosis of SPA by rheumatologist, based on clinical and lab and imaging. Second, in هو there is signs of activity, either elevated inflammatory markers like ESR or CRP, or inflammatory markers in the MRI for sacroiliac joint or spine, or positive X-ray for spine. TNF is approved in some countries without any limitation. And for those patients that are non-radiographic, means non-radiographic, الأكزيال SPA can be divided to radiographic SPA or non-radiographic. الراديوجرافيك اللي هو manifested في البرين X-ray. النون-radiographic يعني no positive finding in the normal X-ray, but البون مارو MRI show positive result. يبقى to start with the biologic, I should evaluate the increased CRP, because in the patient with increased CRP give good response to biologic therapy than those patients with low CRP. And also in the patient with positive inflammatory marker in the MRI give positive more better result on the biologic therapy. Step 3, and after the failure of the standard treatment, either sarazopyrin or non-steroidal, after 3 months from these drugs, we can start the treatment of biologic therapy. Methotrexate can be used in patients with peripheral SPA, but it is not so effective. So in this guideline, refer to sarazopyrin more than methotrexate. Step 4, we should determine the disease activity, level of the disease activity. And I told that in an assess is better to define disease activity. If the patient has an assess more than 2.1 or a Basadai more than 4, I start the biologic therapy. This is the same steps. TNF indicated for an axial SPA. All the TNF blockers اللي هم الاداليموماب، السيرتوليزوماب، الاتامساب، الجوليموماب، الانفليكسماب. Unfortunately عندنا 5 TNF موجودين في المصر. All of them approved for an axial SPA. However, in non-radiographic هم radiographic والnon-radiographic except الانفليكسماب not used في non-radiographic SPA. في another biologic present اللي هو interleukin 17 اللي هو اسمه سيكلينوماب، ده approved في treatment of radiologic SPA, but still guideline start with TNF blocker. يعني not start interleukin 17 inhibitor, because we have more experience with TNF inhibitors, and the TNF are effective with a variable indication with low side effect. هما يعني 2 or 3 slides. لما انت قلنا ان احنا عندنا ان في 5 TNF inhibitors indicated liradiologic و4 liradiologic SPA. Interleukin 17 can be used, but it is not the first choice after failure of the conventional therapy. كمان في ان احنا قلنا ان 40% from patients with spondyloarthropathy have extra articular manifestation. The most common uveitis والinflammatory bowel disease والpsoriatic arthropathy. الحاجات ديت بتخلي فيه limitation في اليوز of TNF type of TNF. يعني الانترلوكين 17 not used في الانفلاماتوري bowel disease. بس ما can be used with psoriasis. الانابريل can not used with patient with IBD, inflammatory bowel disease or uveitis. اللي هم approved الاداليموماب والانفليكسماب والجوليموماب also. يبقى according to the situation of this patient as a pure axial or with extra articular manifestation to choose a better TNF blocker. يبقى الإيتانرسيبت not used in patient with uveitis or inflammatory bowel disease or psoriasis. الانترلوكين 17 not used in patient with inflammatory bowel disease or uveitis. الانترلوكين 17 used only in patient with radiographic spot, and also infliximab used only in patient with radiographic spot, يعني with post X-ray finding. This is الاساس criteria اللي احنا اتكلمنا عليها في different stages in phase 1 و 2 و 3. Each one of these drugs should be monitored. يعني I should monitor the disease activity after the use of any one of these drugs, and not switch or change this drug except after 3 months. If the disease activity score اللي انا بدأت بيه not improved, يعني and the improvement in assess should be more than 1.1 for Albaz or 2. If there is improvement, continue on the same drug. If there is no improvement, this means failure of the biologic, switch to another biologic. If the TNF fails, switch to another TNF. We can switch from one TNF to another TNF in axial spot, or interleukin 17. If the patient in sustained remission, and if the patient whistle in remission, and this remission sustained on the same drug for more than 6 months, 6 months or more, I can taper the biologic demand. Also either by reducing the dose or by increase the space between the doses. Taking in consideration the increased risk of increased disease activity and never discontinue biologic therapy for spondyloarthritis. No hope for patients without this biologic therapy, either TNF inhibitors or an interleukin 17. There is surgical recommendation for the surgical intervention for the staff who have hip replacement or who has acute spinal vertebral retraction. We need orthopedic for this situation, either hip replacement or retraction, or in there is severe angulation of the spine from the joint damage. We can consult expert orthopedic for this situation. And thank you.
شكرا دكتورة ولاء على المحاضرة الجميلة دي. يا جماعة حد يحب يسأل سؤال؟ اتفضل.
شكرا دكتورة ولاء. This recommendation is when an recommendation and our recommendation not having good access to biologic, etc. And you summarize recommendation for our patients.
يعني هو السمرايزيشن بالنسبه للروماتويد طبعا احنا بنستخدم الكونفكشنال سينثيتيك ليمار ايذر مونوثيرابي اور ديوال ثيرابي اور تريبل ثيرابي فور اتليست المفروض ان احنا بنستخدمهم فور اتليست 6 مانثs يعني ابتدي بالمونوثيرابي فور 3 to 6 months الفيلد ممكن اي يوز الكومباينيشن ثيرابي ان انا ممكن استخدم ميثوتريكسيت ويز هيدروكسيكلوريكين اور سلازوبايرين اور لوبيرونامايد يعني ممكن استخدم 2 or 3 الحقيقه الاكسبرت بتاعتنا في مصر بالذات يعني العالم كله بيستخدم الميثوتريكسيت بشكل جامد جدا بيجيب نتائج حلوه جدا ما اعرفش احنا المصريين الميثوتريكسيت ده عامل لنا ذعر ما بين العيانين تقول لك الحقن الصفراء مش ممكن اخدها لو هموت ما اخدهاش ما اعرفش ليه هل ده جينيتك فاريابيليتي بالنسبه للناس المهم طبعا احنا ما عندناش تولز اذر تولز يعني البيولوجيك طبعا احنا زي ما بيقولوا ايه بنطفح العيانين ميثوتريكسيت ودمار حتى السلازوبايرين بيجيب نتائج حلوه جدا
لما بنحضر مؤتمرات وبنسمع على نتائج السلازوبايرين في التريتمنت برضك بيجي لنا نتائج حلو. احنا برضك السلازوبايرين ستيل لحد دلوقتي عشان اديه بالماكسيمم دوز اللي هي 3 جرام بير داي ات از بيج دوز، وبرضك بيحصل منها نون كومبلاينس من العيان، يعني العيان ما بيستحملش الكميه دي. المهم يعني هو احنا الستارتنج بتاعنا الكونفنشنال سينثيتيك ديمارك ايزر مونوثيرابي، الفيلد بستخدم الكومباينيشن ثيرابي. بس في بعض الحالات اللي هي بتبقى سيفير وبيبتدي يحصل، احنا عارفين ان الجوينت دامج في الروماتويد ويزن 2 years، يعني ان ما لحقتش العيان في اول 2 years بيبقى لايبل ان هو يجيله ديفورميتيز جامده جدا. طبعا احنا كرايم مننا ان احنا نوصل العيانين للصور اللي ورتها لنا الدكتوره سمينه بالديفورميتيز دي، انا بعتبرها كرايم، لان هي يعني اعتقد يعني الكوست بتاع الدراج مهما يكن الكوست عمره ما هيبقى زي الكوست ان البني ادم ده يبقى هانديكاب ومحتاج حد يرعاه. فطبعا احنا بنستخدم الكونفنشنال، لكن في واكتر حاجه بنستخدمها التي ان اف، لان التي ان اف انهبيتورز بقالهم في السوق كتير وعندنا جود اكسبيرينس بيهم، وعندنا ان هم يعني الترايلز اللي اتعملت او العيانين اللي خدوهم بيبقى فيري افكتيف دراج والسايد افكت بتاعته قليل. طبعا يعني الريت بتاع السيريس انفكشنز احنا لقيناه قليل برضك، يعني حتى الترايلز برضك موجوده ان في سيريس انفكشن، بس بصراحه يعني مش لاقينها كتير، يعني ان هو افكتيف وفي من غير سايد افكت كتير. النون تي ان اف برضك مجموعه كويسه، وخصوصا الاباتاسيبت. الاباتاسيبت ده جاب نتائج حلوه كتير مع عيانينا، واحنا بنلجا له في العيان اللي بنخاف منه من الريكارنت انفكشن. يعني اللي هو واحد مثلا خد تي ان اف بلوكر وجاله سيريس انفكشن او اتكررت مع كل جرعه، يبقى بنبعد عن التي ان اف وبنستخدم الاباتاسيبت. التوسيليزوماب بالانترليوكين 6 برضك مع الفيلير اوف ذا تي ان اف وي كان يوز التوسيليزوماب. ده بالنسبه للروماتويد. لكن بالنسبه للسبار سبونديلو ارثروباثي الاكزيال 1 يا جماعه يعني دول شباب صغير ميل وفي سن الشباب يعني من 20 ل 40 سنه، ولو ما خدش علاجه بيبقى هانديكاب، بقى فقد عمله وفقد اسرته وما بقاش يعني بقى عالة على المجتمع اكتر من كده. فحضرتك سالتي ان احنا لو ادينا له وهو بقى البامبوسباين، طبعا مش هيرجع البامبوسباين، وهو ده الهدف مننا او من تواجدنا، ان احنا لازم نعالج العيانين دول في الايرلي ستيجز بتاعتهم عشان ما وصلهوش انه يبقى هانديكابد ويبقى عنده بامبوسباين. ولكن الميزه اللي قد تكون في استخدام بيولوجي في عيان البامبوسباين انه تو ريديوس الانفلاميشن او السيمتومز والساينز، ممكن يستجيب يعني يقلل البين بتاعه بحيث انه يقدر يشتغل. احنا الهدف من العلاج تو بريفنت الدامج اوف ذا سباين اور ذا جوينت.
لو انا شخص انا ما خدتش فيه بروجريشن ده في حد ذاته
ما هو ده stop the progression of the disease. If we start very early, we have a good therapeutic benefit. If you start late يعني بتبقى مشكلة. بالنسبة للروماتويد طبعا احنا usually احنا على الرغم من الجايد لاينز قالت ان انا ممكن استخدم تي ان اف او نون تي ان اف، بس الى الان بنستخدم التي ان اف الاول، ومع الفيلير اوف ذا تي ان اف اي كان يوز نون تي ان اف انهبيتورز. في السبار مفيش دراجز معينه اللي بنوافق عليها، التي ان اف بلوكر وبعدين الانترليوكين 17. التوسيليزوماب اللي هو الانترليوكين 6 نوت ابروفد فور سبونديلو ارثروباثي، يعني ولا الاباتاسيب ولا الريتوكسيماب، يبقى انا ما عنديش الا تي ان اف وما عنديش الا اللي هو الانترليوكين 17. في دراج اللي هو الاستيكينوماب اللي هو انترليوكين 23 انهبيتورز، بس واخد ابروفال للسورياتيك ارثروباثي نوت الاكزيال سبار، يعني لسه ما خدش ابروفال في الاكزيال سبار. هنسجل ايه؟ الكوزنتكس واخد ابروفال 17. عشان احنا بلد الهيباتايتس احنا قلنا كان في ابسوليوت كونترا انديكيشن ان انا استخدم البيولوجيك مع الهيباتيتس بي في البريفيوس جايد لاينز. الجايد لاينز الجديده قالت ان انا استخدمها بشرط ان البيشنت لا اما خد التريتمنت وخف او بياخد التريتمنت. لو في البي بالذات اذا كان في اكتف هيباتيتس بي not start the biologic except after the treatment. في C we can use with the treatment. وخصوصا احنا عندنا يعني successful treatment للهيباتيتس C. Any other question?